So I'll be extremely quick. My presentation is Where Flowers Bloom, So Does Hope. And I thank my mentor for giving me the opportunity of seeing such beautiful and rare cases. So a 42-year-old female presented to us with blurring of vision in the right eye since 3 days. And it was associated with mild pain. It was a very vague symptom. And she was referred to us by a general ophthalmologist who had noted raised pressure. And there was no history of any systemic issues or any history of glaucoma in the family. So we have kind of had vague symptoms and we had to put it all together. We went ahead, we assessed that there is absolutely normal vision, 6.6. She's just complaining of blurring. Very nicely, if you notice, she has an anisocoria in the right eye of a difference of 2 mm. And the pressure to us, when she presented, it was 18 mm in the right eye, and left eye it was 16 mm, not on any topical medications, and also there were iris pigments on the anterior surface of the lens. Very closely we went in, zoomed in, and we saw a flower-shaped iris lesion in the inferotemporal quadrant. You can see there was 1 clock hour involvement. There was a small hyphema on the upper edge. We zoomed in further, and then you can see that there are iris pigments on the surface of the lesion and on the lens, and there's a minor tractional fold on the surface of lens, which is basically causing the anisocoria. We went ahead, we assessed on anterior segment UBM, and we saw a height of 1.87 mm and a maximum width of 1.97 mm. And this is basically, we call a raster view, so that we can see if there is any other cystic lesion in the iris, because these kind of patients have a tendency to have multiple lesions. And we went ahead and we put all of these things together and came up with a diagnosis of an iris hemangioma. So basically these are iris hemangiomatosis, which are acquired benign vascular lesions comprising of coiled vascular loops arranged in tufts. These are basically called Cobb's tufts or iris vascular tufts, first described by Fechner and described as multifocal vascular tufts by Cobb. These are 2% of all iris tumors. Histopathologically, it is basically aggregates of small, thin-walled blood vessels. Myotonic dystrophy and diabetes mellitus are common associations seen. Routine slit lamp examination is enough. We can see spontaneous hyphema and increased IOP in these patients. It is crucial that in cases with spontaneous hyphema, increased IOP, we must look at the possibility of NV and NVI. And this patient, it was clear. We could not do a fluorescent angiography and OCT angio, which we did not have for anterior segment, but rapid hyperfluorescence with late staining is seen in these patients. So we have options like observation, topical management, and surgical intervention. So observation and topical management is still okay. Surgical intervention is definitely not mandated, not advocated. In this patient, we chose to go ahead with topical management, or I would say rather observation, and I'll explain how. So moving on, just 1 second. So this is how the patient presented to us after 6 weeks. After 3 months, you can see slowly the color is changing. It is nicely coagulating, and this is beautiful. After 6 months, it is nicely coagulated. The attractional component has reduced, and even the dimensions have improved majorly. So to conclude, you can see excellent results in these patients. We put the patient on topical timolol. That was enough because we kept the high IOP in mind, and also timolol has a beta blocker effect, and therefore the patient improved we put it on twice-a-day regimen, and the patient responded extremely well. So if asymptomatic, it can be left to be observed. If symptomatic, topical management suffices, but regular follow-up is definitely mandatory in these patients. Thank you, and thanks a lot for the wonderful session.
Thank you, Dr.